Hello and welcome to this fabulous webinar entitled Making Surgery Safer, Practice, Science and Data that Deliver. Thank you so much for giving your time up to join us this evening. We've got two great speakers and then myself that hopefully will keep you entertained over the next 60 minutes. I'm going to slightly introduce the first speaker, who's Lindsay Keeley, who's the Clinical Patient Safety and Quality Lead for the AFPP. For those of you that don't know what AFPP stands for, it's the Association for Peri-Operative Practice. Lindsay is then going to be followed by Ryckie Wade, who's become a friend of mine on talking on this subject. And Ryckie is a consultant plastic and hand surgeon from Leeds Teaching Hospital. He's also got other accolades, senior lecturer, and he's an NIHR academic clinical lecturer. So I'll be expecting lots of graphs and statistics, which he can explain in his own language. Before they both kick off, what I'd like to say is that a couple of things throughout the webinar. Please, can you just try and keep everyone muted? We will guide the discussion, but if you guys want to write questions, please drop any questions that you have into the chat box so that we can moderate that. And then at the end of this discussion, after everyone's spoken, then I'll put some of your questions to Lindsay, Ryckie, and if there's anything relevant to me, I'll answer as well. But I think one of the things that we should say is that this event has been certified by the Royal College of Surgeons for accreditation. And if you want the CPD points to be accredited to you, please stay until the end, and then you'll get the feedback form and you will get your CPD points attributed to you once you've handed back the feedback form. So please, please, please do stay. Encourage your friends to join online and listen away. As I said, if there's any questions, please, please, please just drop them into the chat box. Look, without further ado, I'm going to hand over to Lindsay to give the first talk, if that's all right. Lindsay, I'm sure you're ready, and I'll look forward to seeing you all when Lindsay's finished. Thank you very much and welcome.
Welcome, everybody. My name's Lindsay Keeley. As Giles has said, I'm currently a nurse by background and I've been involved with BD from that perspective, looking at surgical site infection. This particular presentation will focus on practice improvement, operational watch-outs, covering evidence-based measures to reduce surgical site infections and practical interventions that everybody can use and reduce preventable harm and surgical site infection risks within the peri-operative pathway. I will discuss the Joining Hands initiative, which I've been involved with, the current consensus, recommendation for skin preparation, which includes clipping, hair removal, wound irrigation, and the APP, NHS England BD skin antiseptics decision tool, which I was involved in, and important operational risks that practitioners need to recognise, particularly around intraoperative use of biocides, skin antiseptic pooling, and surgical fire prevention. So these are the objectives for my presentation, which we'll go through as I'm going along. So the Joining Hands initiative, which is what I was involved with, was a study which BD put together using and trying to develop a universal evidence-based surgical site prevention bundle across numerous surgical specialities. This commenced in November of 2023 and had multiple authors involved in the actual study. Trijusive were a commission to support this and facilitate the project, which took the form of a Delphi methodology. For those that are not sure what that is, that become apparent as I go through this presentation. There was 36 statements on surgical site infection, which were established in 33 of them, achieving a strong consensus agreement of greater than 75%. So this is the purpose and scope and the key aims of this presentation. It's to look at these 36 proposed surgical site infection prevention statements, of which 33 achieved this strong consensus among over 820 European healthcare professionals. The consensus statement covered preoperative, intraoperative and post-operative measures with a high evidence backing. This expert-led evidence-based care bundle that was put together is designed for broad implementation across specialities and countries to standardise surgical site infection prevention, which currently is still not where we want it to be. So this was the responders' role. So these are the people that were involved in the survey that responded. And as you can see, it is heavily weighted towards the surgeons' responses and nurses. So this may affect on the results, which I'll show you as we get further through the slides. The responder countries, as you can see, the main responder on there was Spain, followed by Italy and the United Kingdom. This was reviewed numerous times due to the lack of response by various people within different countries, but this was the ultimate consensus that we used within the Delphi study methodology that we undertook. The responder speciality, as you can see, that covered numerous different specialities. The one that you're actually seeing most is the general surgery was the highest number, and also was GI, which counts for about 222, which you can see there. That is and will affect some of the actual interventions that I'm going to talk about as I'm getting through the presentation. So this is the Delphi methodology study that was undertaken. It was to look at the surgical care bundles, as I've stated, to reduce the risk of surgical site infection. So out of the 36 proposed surgical site prevention statements, 33 achieved a strong consensus among 820 European healthcare professionals. This consensus statement covered, as I said, there were all three areas of the preoperative pathway. There were expert-led evidence-based care bundle, which was designed to have a broad implementation and measures across the whole of the patient's journey. This actual conclusion that came from this was that Europe had achieved strong levels of consensus among the actual statements that were there, and I'm going to allude to them as I get through the slides. So surgical skin antiseptic principles. So they remain one of the most important interventions for surgical site prevention, but they are not where they need to be, and I'm still seeing when I go out inconsistent practice. So there's effective preparation requires both product selection and correct application technique. There is a lack of education in and around this technique, of which there is some support within this presentation that can help with that. The biggest risk we've got is inadequate drying time, people wanting to put drapes on patients too quickly. The applications and the devices and the instructions are provided to reduce that, but we're still seeing people not actually adhering to the instructions or the teachings that are being provided by the various suppliers and teaching that they provide within the hospitals. So this is a surgical skin prep decision tool that got involved with. And this was based on the fact that we had inconsistent practice, both in the NHS and in the private sector. The decision tool helps you to select, it's a digital format which you can go into by going onto the website or the link that is on the slide here. It can be used as a teaching method. It can be used actually in theatre at the time that the patient comes in, if you're not sure of what skin prep to use, depending on what surgical speciality you're doing, what procedure you're doing, and whereabouts on the body that you need to prepare the surgical skin antisepsis. It looks at procedure type, anatomical position, which you can see in the bottom of the middle of the slide, and you just click on that and it then takes you back to actually a breakdown of what you can use, where you can use it, if they've got an allergy, what's the next prep that you can use, your actual technique of how to use it, and also how to get rid of the product afterwards from a sustainability point of view, which we're all sort of looking at in this day and age at the moment. Also at the back of this decision tool, there is a big area with all the research evidence-based documents that are there. It's not just a link, it's actually the documents that you can use to support this. So as I was saying, this supports decision around evidence-based practice to do with surgical site infection. It helps support optimal skin antisepsis process and considers individual patients' underlying health status, procedure type, and expected length of surgery as per the NICE guidance. It has the benefits of standardisation, reducing variability, improved compliance, and enhanced patient safety, which is paramount. So this next slide basically shows you how the single-use devices, when you're thinking about it, and how the tool can help with that. It's about this informed decision which comes from research and evidence base. The single-use application technique reduces risk contamination, it reduces errors, it reduces inadvertent accidents where you have got free fluids on your theatre trolley. Also, once you've actually used the application stick, you can throw that away, removing any risk of leaving any fluids that are not identified or labelled on your trolley, which is important that we need to label everything that we're using on a trolley and remove any fluids that are no longer needed. We've also hit on here, which is the risk of multi-use bottles. Now, the biggest issue with bottles that we have in theatre is they move from theatre to theatre, that they're not dated, there's not a time on them. When you're doing particular specialities, like orthopedics or where you're putting implants in, you've got to be careful that you are using clean, sterile surgical skin prep. Where with using the multi-use bottles, they are not sealed when you get them, and there is a risk of contamination. And there is also research evidence base that states that there is infection can collect around the top of the bottle, and it has been about that way you can actually pour that. Obviously, then you're at risk of increasing the risk of a surgical site infection to the patient. Regards to the bottle use as well, if you're pouring a lot of fluid into a galley pot, you don't know how much you're doing in there. Swabs get soaked in that. You are then using the swabs to prep the patient, and you've got increased risk of extra fluid around the surgical incision site that you're actually going to be operating on, and that can reduce the risk of a diathermy, fire, or any other area where you've got pooling. You've got to reduce the risk of actually that pooling around. It can also affect the skin as well. So hair removal was one of the elements that we looked at within this bundle. Hair removal should be single use using a clipper. The clipper should be disposed of after use. The other thing around this is there is no teaching, there is no education, which is standardised across all of hospitals. You find that people are using it just how they feel it should be used. They're applying too much pressure when they're actually using the clipper, which also can graze the skin. So it's important that you get the appropriate training for this. They are instructions for use, and you avoid using razors or any creams or any pre-operative shaving, as this also increases the timeline before an infection can start and risk around the skin site where you've actually used the clipper or the razor. So the hair removal should preferably be undertaken outside of the operating room. Now, the evidence states out there's numerous guidance out there. Some say do it in the anaesthetic room. Some say you can do it in theatre. When people do it in theatre, you get hair everywhere. It just goes into the air down the side of the patient. People blow it away. They're using loads of different devices like sticky mitts and things like that. They're using surgical tape, which is not intended for use to remove surgical hair, but there's various different ideas and techniques that people bring into this. So it's important that you use the devices that are there for you, and equally look at your procurement guide for support regarding getting hold of these if you are unable to get them in your hospital, and equally speak to the reps. The main thing important here is not to remove hair unless it's absolutely necessary, and even follow a surgical site bundle that the surgeon may have as well. They may have other ideas where the patient might be served prior to coming to theatre. So this is the best practice for removal of hair and also for skin prep. It's important that when you're thinking about this, that you're actually looking at the practice that you're obtaining, and equally how you remove the hair. You may or may not need to remove the hair, so wherever possible, reduce that. The skin prep that you're using, that may be decided by the surgeon. They may have particular preference, so you'll be using what the surgeon is requesting you to use for that particular procedure. It may mean that even though that has been selected, that the patient may have an allergy to that particular surgical skin prep, and therefore I would potentially use the surgical skin prep decision tool to help you decide what your alternatives are there, and speak to the consultant at the time. Your first choice should always be alcohol-based clexidine, and that is the choice that is being advised by NICE, and there's numerous research and evidence base out there to support this practice. Always be aware of, obviously, if you're operating areas where there is mucous membranes, eyes and ears, you would be using then an aqueous solution, and also make sure that the patient is not allergic to that, or you can use the aqueous CHG, which is written on there as well. So this is where this decision tool can help you with regards to how and what you can use regarding the skin prep. You need to allow enough time for this to dry again. And if you're using an application stick, obviously you've got a minimum amount of solution, and the drying time would probably be around 3 minutes. Different companies will or may say there might be different versions of that, but roughly about 3 minutes. When you've actually got a gallipot full of fluid, as I mentioned earlier, and you've got a swab on a stick, you're going to gather more fluid in that swab, and therefore the drying time may take longer, and you can have increased risk of pooling around the patient or the incision site. So wound irrigation, now this is something that as healthcare professionals that we tend to do quite a bit of, but we don't often know the reasons behind what we do and how we do it. So it continues to generate a lot of debate. Selections should be based on available evidence and surgical speciality. The general surgery in particular, which I demonstrated already on the Delphi model, that is an area where they tend to use a lot of surgical irrigation, wound irrigation, particularly for general surgery and GI surgery. Also, you need to think about the recommendations and any policies they've got in place and protocols. Do you have any of these? And if you don't, then it's important that you look and see if there's any in your organisation. It was trying to get as well a standardisation and of what we actually use for wound irrigation and what's the best use for the patient. And there is variation depending on what speciality you are actually preparing for within the surgical field and what the surgeon's preference is as well. The important message is not that irrigation should never occur, but rather the evidence remains insufficient for universal adoption of antiseptic irrigation in all procedures. It's mainly bowel surgery where you tend to see a lot of this. Equally, the other thing I would suggest to think about, which is something that not everybody is aware of, is does it need to be warmed and how does it need to be warmed and what temperature should it be as well, depending on what product you're using. But I would follow the instructions for use by the supplier. So this is one of the solutions that BD produced and have just recently hot on the market. So this makes it very easy. It's a sterile, sealed in the container. There's no contamination in it. It's single use. Once it's finished with it, it's removed. And it would be one single patient use only. So this would be a strong recommendation within a peri-operative governance to reduce the risk of surgical site infection, and also could be part of prevention strategies and even your surgical site incision infection reduction for a bundle even. So practice recommendations. So I would adopt a skin and antisepsis. Always use single use wherever possible. I know that isn't always the case. Make sure that the sterile prep solution rather than a multi-use or multi-dose bottle. So, make sure that the sterile auxiliary materials are there as well, and clipper only for hair removal. Avoid using the razors I've already mentioned earlier, and avoid using wherever possible unlicensed chlorhexidine biocides, which we know are on the market at the moment. Reuse of applicators, again, to avoid those, and also to be aware of that irrigation with non-sterile solutions isn't very good, and it can actually increase the risk of a surgical site infection. So the consensus says that the use of licensed solutions, the joining hands panel, echoed that there was 90% agreed that all skin prep agents, applicators and materials used in surgery should be licensed for their intended use. So this is the difference between licensed products versus biocides. And when you're thinking about this, you need to think about what are you currently using in your practice? Are you aware that you're using a licensed product or a biocide? I have received lots of calls from members about people working in practice where they've been given a different surgical skin prep solution or applicator. They're not aware of it. They're not sure how to use it. They're not sure of where they stand from a practitioner point of view. So it's important that you make sure that it's licensed, the patient is aware of it. If it's unlicensed, there should be some documentation or protocol. You should only use an unlicensed product when there is no other product available, or is there a clinical reason why you should be using that for the patient. This actual slide, it looks at producing and supporting the patient. Try to use this standardised practice and using continuous licensed products that are actually registered for use via the MHRA. It's making sure that you're reducing organisational risk and ensuring regulatory compliance, and it produces a good evidence-based practice. So The biocidal products, as we know, are not licensed for use as a surgical skin prep, although we are aware that certain organisations and procurement teams have been pushing for these from a cost saving with the NHS, and this shouldn't be about a cost saving for something that is to be used not for a special or a clinical reason for a patient. This should be looked at on an individual basis if that's the circumstances, but they shouldn't be flooding the operating theatres because they are cheaper to use. So the consensus is basically to use a licensed product wherever possible, unless there is a particular single advice or single reason, clinical reason why the patient might need to have an unlicensed product used, or you can't obtain them for the patient, or there is a supplier issue with us getting hold of the product. So the governors, when considering using these, is thinking about basically what you've actually are dealing with when you're looking at the unlicensed product. The use of unlicensed skin preparation products only when suitable, licensed is available due to the patient-specific need, e.g. allergy or temporary supply shortage. Equally, you need to think about prescribers remain responsible for oversight monitoring for adverse events. So if I'm applying that as a registrant, I to know what I'm applying to the patient, what are the risks there, and what the product is, what it does. You know, is there any side effects of this? With the unlicensed products, there has been some people contacting me saying that it's okay to use it in certain hospitals for paediatrics if needed, or in some places they're not using it for paediatrics and using it for adults. But therefore, you shouldn't be using it when it's not standardised and it's not licensed. There is a white paper out there which produces specific information around this as well. An organisation should consider informing patients when an unlicensed product is used to support transparency and trust. And it's really important that that governance is there. So we're looking at this slide. This is the governance and the transparency around unlicensed products. And equally, we need to think about, in relation to this, what does that actually mean? And what is the transparency that needs to happen? So it's making sure that we, as a last resort, only use licensed products, and need to make sure that this documentation, this governance, this process, policies are in place and people are aware of it. The MHRA has produced guidance out there, and so has the Royal College of Surgeons, to support the use of licensed products versus unlicensed products. So the perspective on biocide. So when you're thinking about the governance, the organisation, you need to adhere to the current practice that's out there and the guidance, as I just mentioned, from the MHRA and the Royal College of Surgeons. Avoid the multi-use general disinfectants because they are not licensed for surgical skin prep. And if you go on the websites, it actually says that they are not licensed for surgical skin antisepsis, and they can particularly be prone to contamination. And equally, you can have side effects, and equally patients getting rashes. I think there has been some incidents of that. You need to make sure that procurement are aware of this, and also review any local policies or protocols that you have. And if you have any issues, you can always contact the MHRA regarding the current requirements and the evidence that is currently available. So when we talked about pooling and surgical skin prep, there is a lack of education, teaching and guidance around the risk of surgical fires. Surgical fires do occur. I've done quite a lot of work on this and research on this. This is basically around the use of alcohol skin prep, pooling, not allowing it to dry, people not having the proper education around how to apply the alcohol surgical skin prep that you're going to be using. People aren't aware of the triangle and what actually can cause a fire. I have been trying to get hold of the data from NHS England. We're still currently waiting for that. When I go to conferences, I'm always being contacted or spoken to regarding people that state that surgical fires are still occurring. They keep telling me that patients are catching fire. And I did actually speak to a patient who actually did catch fire, and he said he was on fire for about 15 minutes before they realised he was on fire, and that was due to because they were using alcohol. You can't see it when there's actually a flame and it's under the drapes and people aren't aware of it. And the immediate reaction for the staff was just to pull the drapes off and stamp on it. So this is why there's a lack of national standardised guidance around this, and training and scenario training within organisations. This actually poster helps you with this and looks at all the different devices that are in theatre that could potentially increase that risk of a surgical fire. So it's important that we reduce the risk. So we need to think about preventative measures. We need to look at what I spoke about earlier, volumes in gallipots, reducing that. So this is why an application stick is ideal for that. Looking at the drying time before you're draping. Don't let the surgeon grab the drapes off you. Make sure that the skin is dried, and then the drapes will stick to it as well. And having communication and whole team training, and even discuss it in a team brief. This is something that's never ever explored in a team brief. And in all the years that I worked in ENT theatres, there was never the information that provided with regards to, is there a potential risk of a surgical fire occurring? What do we have available, and what would we do if that occurred? And that was particularly in ENT and laser surgery many, many years ago that I worked. So it isn't something that we should neglect. It is something that we need to have the research and evidence behind it, and the training for all people that are working in the peri-operative practice. So these are some insights from real world practice. So these are the things that I am seeing when I go out there. Again, there's insignificant information being given to people. There is not standardized practice. People aren't given the education around this. There is also sometimes people are using the unlicensed products. They don't know the difference. They don't know what that means. APP has produced some guidance on that as well as the Royal College of Surgeons and MHRA, and we're currently doing some work around that to educate and advise all healthcare professionals that are working in peri-operative practice. So it's important that the choice of surgical skin prep is chosen for the right reason. And equally that we talk to the procurement teams of the hospitals with regards to any sort of supplies of biocides or unlicensed products, and why they're actually turning up in operating theatres and nobody's being told about it, and there's been no education or nothing to support people. So the risks still continue, they're still out there. There is still pooling occurring because practice, is hit and miss. And when I go out into audits, and I will see people in a whole theatre department all doing something different, and also not providing the support and education to the staff, or even highlighting that there is a risk of a potential surgical fire. So we need to think about this whole team support, this multidisciplinary team within the theatre as well, and how to educate and then audit your practice to make sure that what you're doing is research and evidence-based, and you've got the documents to support, you've got good governance around it. And then you need to check that it's embedded. So you need to continue to audit. So the conclusions, the messages here is always look at the evidence-based surgical site prevention bundle and use it consistently. This, again, not people are aware that there is a surgical site prevention bundle. They don't know what it consists of. They don't know what's in it. They don't even know if the patient's got, on a surgical site infection prevention bundle at all. And this is something that I think practitioners need to be aware about, because we're so busy doing certain aspects and elements within the bundle, we don't put it all together and join it up. And we're all doing different things at different times to the patient. So I think that education around bundles and each practitioner's role within theatre is really important. They need to be aware of the various teachings around the hair removal, is it needed or not, and how you use it and when to use it. Also think about your license, your unlicensed products, and what that means and what you're actually using within your departments, how to reduce the risk. I particularly went down to a single-use bottle for ophthalmics, because when I was working in the area that I was working in, they were using a multi-dose bottle and they were titrating it as well. So they weren't titrating it with the right amount either, and it was used for a whole list. And then potentially, what is actually in that bottle, what's around the edge of that bottle. Whereas at least the bottles I were getting were sealed. Unfortunately, they were unlicensed, but in order to reduce risk and harm to the patient, I sourced the solution from another hospital who prepared that to support me with that. And we put governance around it, we put a policy in place, patients were informed about it, information was given, and every single bottle, lot number and everything was written down for that patient. That was part of the policy. So this is important. It's important to be able to mitigate the risks regarding this. Thank you.
Well done, Lindsay. Absolutely perfect there. There's so much information. There's lots of questions already been listed up there for you, which I'll deliver at the end. I am now going to hand over to Ryckie. Are you there, Ryckie?
I am. Can you hear me?
Brilliant. Over to you, my friend.
Coming your way.
There you go. Can you see your screens?
We're live, ready to go.
Yes, you're
So,
off.
this section of today's webinar is all about skin antisepsis. And my talk's got two sections. So if you're like fully clued into why alcoholic chlorhexidine is the rank one choice, then you can zone out for about 5 minutes and then I'll wake you up. And the second half is going to be the new cool science, cutting edge, pointy frontier of where we're at with skin antisepsis and where things are going next. And this is obviously important. We're all here because we do a lot of surgery, some 313 million operations a year globally. And despite our best efforts, infection is still the most common and costly complication of surgery. And yes, all of our guidelines tell us clean the skin with alcoholic chlorhexidine. But why? I hear it very often. People say to me, why, Ryckie, is this the case? You know, we've used other stuff for a while. Well, it's all based in a ton of evidence. And this is where it's come from. So here's your whistle-stop tour of history. Over the past several decades, many studies have been done, and we're talking about trials here, of skin antisepsis, one versus another. And when studies are sufficiently similar, and they're done well, et cetera, we can pool them together in what's called meta-analysis. And this is far better. I'm really going to nail this point quite hard because any single study, even if it's big and it's brilliant and it's done by great people, it can be wrong just by chance alone. And by bringing together lots of studies together, we get much closer to the truth, the reality of things. And that's why meta-analysis is right at the top of the evidence hierarchy. And that's what people have done for years and years. They've done various meta-analyses of various antiseptics, one versus another. And that was great, but it was also frustrating because it's impossible to say, well, which one's the best? And so the rows went on and on and on. And I decided to try and solve the problem using graph theory, which is a very well-trodden mathematical technique. In fact, if you use Google Maps, it's exactly the same maths that gets you from A to B. But the cool thing about it for healthcare applications is that we can synthesize what things might look like, even if they've never been tested. So, for example, A versus C, if nobody had ever bothered to do that trial, well, network meta-analysis can tell you with pretty good precision what that would look like, in the same way Google Maps can route you from here to your mate's house, even if you've never been there. And the next best thing about it is, never mind that it's more powerful and better than all the other kinds of healthcare science, it can rank treatments, best to worst. And that's what we did in our seminal paper in the Annals of Surgery several years ago. Our network meta-analysis in clean surgery, and I'm going to talk a bit more about why clean surgery later, but it showed pretty convincingly that compared to the favorite, the most prevalent antiseptic at the time, alcoholic formulations of chlorhexidine were, on average, better. They reduced the risk of infection. So if you swapped from this to any formulation of alcoholic chlorhexidine, the risk of infection goes down, and it goes down by quite a sizable amount. Now, of course, no research is perfect. And the next iteration of this work by Hastie and her group out of Meyer's laboratory in Amsterdam built upon this more. They took a slightly different angle. They went past clean only and included surgery of all types, but limited it only to randomized control trials. So that gives a cleaner signal, but in a more heterogeneous data set. So a totally different perspective on a similar question, and no prizes here, but the answer was the same. Compared to the community favorite at the time, alcoholic chlorhexidine was much better, significantly so. And both of these seismic studies gave us a glimpse into a potential dose-response effect of chlorhexidine. And even though our guidelines all around the world just say use alcoholic chlorhexidine, in fact, the NICE guidelines literally say your first choice, unless it's contraindicated, should be alcoholic chlorhexidine. But you and I all know that when you're there in the theatre and you reach for the antiseptics, that there are loads available. It's like a sweetie shop on the shelf. All sorts of colours, sprays, applicators, bottles. And I think it's only fair to say most people are unaware, and rightly so, of which one is best, even if they're all alcoholic chlorhexidine. So I set about to try and solve this problem. And about now, I should say a big thanks for BD inviting me to give this talk here. But by the same token, it's important to reassure you that none of the companies with whom I consult with have anything to do with the research that has been done and I'm presenting now. So several years ago, I assembled this team to try and tackle this question of, is there a dose response of chlorhexidine? Is more chlorhexidine better? Is a stronger chlorhexidine better than a weaker chlorhexidine in alcohol? So Holly's one of our clinical academic doctors. Angus, he's one of our NIHR clinical academic fellows in plastic surgery. And Hugo Pedder is the creator of this whole statistical regime. So he invented this technique and the code to do it. So he's more or less the global authority on the topic. And I'm so super happy that this team did this with me, and I can't give them kudos enough. If you want to read the paper, it's at the DOI below. So wake up now if you've been snoozing and you don't like history, because now is present and future. We pulled 31 studies from the literature. It's all about clean surgery. And I chose clean surgery very deliberately because it's a perfect model for looking at skin antisepsis and SSI. It's very, very different to hollow viscous surgery when you might have done a great job of cleaning the skin, but then poo goes everywhere. That almost nullifies your skin antisepsis. So here we have clean the skin, do the business, and then what we observe afterwards must be related to what we've done before. And we have an enormous amount of data, 11,500 patients worth of data, and we're talking about SSI. Here, we were really spoiled. We had such a lot of data, and this is what we did. Firstly, for parsimony, we started with a simple model, just looking at antiseptic in solvent. And we looked at the effect, and of course, it was exactly like all of the previous data had shown us. So we thought, right, let's get on with what we wanted to do, which is look at dose. So this network plot shows us all the studies that are in this meta-analysis. The blobs, these nodes, relate to how many patients have had that treatment. You can see down here in the legend. So big blobs means we've got loads of patients there, and the little blobs mean fewer. The lines between them are the number of studies that have done this research. And these are RCTs, by the way. So here we've got tons of RCTs that have compared chlorhexidine 2% versus povidone iodine 0.7. But we have none comparing these two, or these, or these, and few for some other ones. This was fine. We looked at this. The network was good. It was strong. But I wanted to go further, and I wanted to explore solvent as well, because there's some evidence that solvent has an additive effect, an interactive effect. It may be dogmatic, but it's very well entrenched, and I thought it warranted testing. But it introduced a lot of problems in the data set. It introduced heterogeneity and inconsistency, and you don't need to know what that means, but suffice to say, that was not a good thing to do for the data. We tried to fix it by seeding in the global data from non-randomized studies. Those studies are a little bit more methodologically flawed. There's potential confounding residually, and so on and so on. And even by seeding in that absolutely colossal amount of data, it didn't fix the inconsistencies and heterogeneity. So although all of the data is presented in the paper for transparency and all the raw data, this is what the main message is coming from. a network of RCTs of thousands of people looking at different doses of antiseptic. Right. We made this plot, so I'm allowed to say I don't like it. It's the primary plot in the paper. It's scientifically perfect, but it's not very pretty. And it's very difficult to explain it to colleagues if they don't have a really robust background in stats. So forgive me, but I'm going to change it a little bit for our presentation. Please stop reading the slide if you're doing that now. I'm going to walk you through this plot. So up the side here, the y-axis, we have different concentrations of antiseptics. Iodines at the top, chlorhexidines at the bottom. Down here, we have the risk of infection. Don't get hung up on risk or odds. This is a Bayesian framework, and risk and odds are very similar because it's uncommon. But what I want you to understand is that on the left of the plot is reducing the risk of SSI, and to the right is bad. That's increasing the risk of SSI. And the position we're starting from is what the guidelines say. Chlorhexidine, and it's with the most prevalent data that we have, 2%. So this is our best guess at what is best. For the talk right now, I'm going to really drill in detail chlorhexidine, because let's face it, most people are getting prepped with that. And that's the one where we have the uncertainty. So here, if you choose 2% chlorhexidine, but actually maybe procurement has given you something else, or your colleagues have made you use something else, I want you to now imagine this scenario. They've made you swap to a chlorhexidine that's 0.5%. Well, the risk to the patient is now increased 5-fold for SSI in clean surgery. It might be as little as doubled, or it might be as much as over 10 times the risk. But the best data available today says that if you drop the concentration down to a 0.5%, you're exposing your patient to a higher risk of SSI unnecessarily. And you might at this moment be saying, whoa, Rick, look, this dot's more to the left. Why don't we get chlorhexidine of 4%? Well, the simple answer to that is neither 4 nor 2.5% are commercially available. Not in this country, and to the best of my knowledge, not anywhere in the world. So really, it's a much more simple equation than this. When you're presented in theatre with an option of either 2% or 0.5%, because those are the formulations that are available in this country, the answer is crispy clear on efficacy. 2% is more effective in preventing infection. But here comes the caveats. It's only responsible of me to say the problems with the data as well. And you'll notice that I haven't recommended you use 2% because there are some safety and uncertainties and some health economic concerns that we still have. So firstly and foremost, when you're doing a study on dosing, you're trying to find the perfect dose. Usually these kind of studies are done with placebo, like compared to a placebo, so that you know exactly where the intercept is, like what's the effect of doing nothing. But we don't have that in SSI, so we got a wet thumb in the air and guessed. There are some problems with that, but it is impossible to rectify, I don't think, in an ethical way. I have to say that adverse event data for antiseptics has been reported very poorly, almost universally. So it would be irresponsible to say, crack on and use stronger antiseptics instead of weaker ones, when we don't know if that translates to more toxicity or adverse events. It may be absolutely fine, but we need more toxicity data to be confident about making safe recommendations. The solvents in 2.5% chlorhexidines in the various formulations available, they are different alcohols. We just don't know if that makes a difference or not. Obviously, this is all clean surgery. So if you don't do clean surgery, you're well within your rights to say this data is not generalizable to me, and I will continue doing whatever I do. That's totally fair. We also don't know about the economic impacts. One product may be more expensive than another, but the adverse events may be rarer. So overall, the health economics may be more favorable for one versus another. And that's why overall I say we have a really strong signal that we're really confident in, that 2% chlorhexidine is more effective in preventing SSI than 0.5%. But this is the perfect scenario for a head-to-head trial of the two with a health, economic, and safety bent. I hope that made sense. I'm, of course, more than happy to chat through any topics towards the end.
Thank you very much, Ryckie. Every time I hear you speak, I'm frantically writing notes and trying desperately to understand what you're saying. It's just amazing. Thank you. Thank you. Right, I'm going to very quickly try and get through my talk, which is basically a little bit about the data, using data as a lever for improvement in surgical site infections. There's the usual disclaimers that the words I'm saying are from me and not from BD, and that I have some declarations to talk about. So the aim of my talk really is going to be what does the evidence and data look like to optimize our surgical site outcomes, and then I'm going to talk a little bit at the end about a new, brand new wound classification system. So when we talk about surgical site infections, they are clinically important. 37% of hospital-acquired infections are surgical site infections. But materially to the patient, you're twice as likely to die, 5 times likely to be readmitted, and 60% chance of going to ITU if you develop a surgical site infection following your operation. The length of stay goes up, and actually, for me doing sort of cancer-related surgery, especially in HPB surgery, the number one reason for missing your post-operative chemotherapy is delay by surgical site infections. So surgical site infections have a huge clinical impact on the patient's recovery. They're also way more expensive than we think. They typically cost around 700 million plus to the NHS, and that's just in hospital and primary care costs, without taking into consideration lost earnings, et cetera, from the patient. So we're talking, into the billion or billions of pounds each year. And when we look at sort of specific specialties, so colorectal, we're talking about an open colorectal surgery with a deep or organ space infection being around about $100,000 on top of your expected costs. Hysterectomy is $40,000. HPB surgery is around $50,000 to $60,000. Cardiothoracic surgery is about $70,000. This is hugely, hugely expensive, and we need to do better to reduce costs for our healthcare system so we can spend it in a more sensible manner. So apart from clinical, financial, there's also environmental impacts. The average surgical site infection produces about just under 600 kilograms of CO2. There's about 65 kilograms of plastic waste. And then there's just under 500 cubic meters of water that are used to treat each SSI overall. And if you think that sounds a lot, you have to think about, someone has an SSI, think about all the dressings that are used in treating that. Think about the journeys that the patient's having to take backwards and forwards to clinic or to the GP or to the tissue viability nurse, etc. All that driving adds to the CO2, etc. But at the end of the day, the wound is the only thing that the patient has a look at. And if they get an infection, it could be an amazing operation. But if they've got this infection, it's all gone horribly wrong for them, and it really negatively impacts on their sort of experience and their recovery. So we've got to have a strategy to bring evidence together to reduce our SSI rate and overall improve our outcomes. And that takes the form of a bundle. So this paper was written by a good friend of mine, Professor David Leeper. It's a meta-analysis looking at about 8,500 patients over 13 studies. And what it really says, that risk ratio of 0.55 means that if you bring an evidence-based bundle together, you can reduce your SSI rate with that evidence-based bundle by about 45%. To back that up, there's another one that was presented in 2017, the Journal of Gastrointestinal Surgery, which looked at nearly 18,000 patients over 23 studies. And what this demonstrated, specifically looking at colorectal surgery, was that if you brought an evidence-based bundle together, you could get a reduction in your SSI rate post-operatively of around 40%. These are big numbers, and we can have a significant impact on our patients. Look, the World Health Organization, NICE, the CDC, they've all got their sort of guidelines for how we best reduce our surgical site infection rates. And I've just put 9 really simple, cheap interventions that you can use that have got significant level 1 evidence behind them to consider putting into a bundle for whatever surgery you undertake. It's pretty homogenous there. The one thing I would say is that glycemic control, we're aiming really to keep glycemic control between 6 to 8 millimoles per litre, even in non-diabetics. That's a tough one, and I would potentially think about that before implementing it in your first bundle. But the others, you should all think, hey, we do that already. The question is, do you, and what's your compliance? So we heard Lindsay speak earlier about hair removal, so I'm not going to go into it in too much detail. But what I would say is that we should definitely not be using razors. We should only be using clippers, and we should only be using clippers if required, and ideally outside of theatre. Now, I can see in the questions, there's already a question that says, well, theatres are being built without anaesthetic rooms, and I absolutely get that. And one of the things that we do is that at the time that the patient's being consented, then they are clipped in that area, be it in the in this sort of day case admission area, where you get consented. We clip the diathermy space and also the wound should it be needed. So there are alternatives, or we do it up on the ward before the patient's brought down to theatre if they're an inpatient. Normothermia has got a huge amount of evidence behind it. And here's the thing. How many of you, honestly, hand on heart, when you're doing the WHO checklist right before theatre, and that bit in the sign-out that comes up and says, normothermia, everyone says, turn on the warming blankets. How many people here say, actually, what is the temperature at knife to skin? And that should be documented. And you should be looking for your patient to be 36 degrees or above. Remember, for every 0.1 of a degree below 36 degrees, your SSI rate significantly increases. And you can see there from that forest plot, a bit like some of the graphs that Ryckie was showing, that if you get normothermia, you can reduce your SSI rate significantly by keeping the patient normothermic rather than hypothermic. We've heard from both Lindsay and Ryckie about 2% alcoholic chlorhexidine and all the evidence behind that. I really hope you take that home. What I'd also take home is the fact that we should be using a licensed product. The MHRA, the Royal College of Surgeons, the GMC and the BMA all say that we should be using a licensed product and only not using a non-licensed in exceptional circumstances. So again, when you've listened to this talk and gone back home to your base hospital, wake up in the morning and think, is the product I'm using licensed? Because at the moment, the only product on the market is that one in the picture. We've got some innovative products to further drive change. There's antibacterial sutures, triclosan-coated sutures. There was a big sort of study that was done called the Falcon study that said that these sutures actually don't work. And that went against a lot of evidence. So Maya Baumeister, who is a real queen in this space, you heard Ryckie talking about her earlier, and Lindsay also was recommending, name checking her in papers. What we did with Maya was we did a big meta-analysis, and we included the Falcon study. And the Falcon study was the largest study to go into this meta-analysis, and it had the heaviest weighting. And even that study didn't change practice. It still came out that antibacterial triclosan-coated sutures reduced SSI rates by up to 25%, and that was significant. And then we've got another new kid on the block, this product, Surgifor, which can reduce, there's good evidence. Again, meta-analysis looking at irrigating wounds before closure with aqueous povidone iodine. This is 21 studies, nearly 5,000 patients demonstrated a 32% reduction SSI rates. What I would say is, having used this product, is it's dead simple. It's consistent. You know that the concentration of aqueous povidone iodine you're getting is consistent from bottle to bottle. But also, when you squeeze it and jet it out, you get not just the effect of the aqueous povidone iodine being in the wound. You also get mechanical disruption of the soft tissues to knock off any dead or loose debris. So look, what you should be thinking is, I'm going to bring a whole bunch of evidence together, no more than 10 points, really, and I'm going to implement them as a surgical site infection reduction strategy. And we did that in Oxford. We had a 10-point bundle, and we did it across all our surgical specialties, slightly altering them depending on whether it was orthopedic, spines, neurosurgery, cardiothoracic, general obs and gynae, whatever. We altered it according to them, but every specialty had a program to reduce SSI rates, and the results are absolutely amazing. 15.3 million we saved in our trust in 1 year. We reduced our excess bed days by 87%, and overall our SSI rates reduced by 50%. And you can do this in your hospital. You really can. You take all the evidence you've heard from Lindsay, Ryckie, myself, bring it all together into a bundle and implement the bundle. But how do you communicate your outcomes? Well, myself and a group of experts from around the world have come up with the new wound classification system called DISH, which addresses the four main elements of wound healing, which is dehiscence, infection, seroma, hematoma. That slide there is the full detailed version, but I'll break it down, make it really easy for you. The scoring system is 0 to 4 in each element. A 0 is the element doesn't exist. 1, the patient is worried, but nobody else is worried. So that's the kind of thing where the patient may go and see the GP and say, oh, my wound looks a bit red, and the GP says, don't worry about it, just keep an eye on it, only come back if there's a problem. So that's 1. 2, doctor worried, but doesn't touch the wound. That's maybe prescribing antibiotics or gently cleaning the wound for a patient. 3, you do something to the wound under local anesthetic, and 4, you do something under general anesthetic. So a very, very easy system to score all our wounds. And then to give it some clinical context, each element has a definition which you can look at, and it's graded A, B, C, D. I won't go into that too much detail. But just so you know that this new classification system is applicable to every operation wherever it occurs on the body. So what I'd like to say on behalf of Lindsay, Ryckie and myself is that you should go away, create your own evidence-based bundle. You should look at the evidence, what fits your surgical specialty, your hospital, wherever you may be. Build that protocol together, implement it, and measure your outcomes. I'm going to stick up my details just at the end there, so that you can take my email address and phone number. If you're interested in knowing more or you have some more ideas, please do let me know. I appreciate we're right on 6 o'clock. I'm sorry I had to skip through my bit as quickly, trying to bring it just going on. I'm being told, whispered in my ear, that we're going to be we're going to have 10 minutes just to go through some questions. And what I'm going to look at, he says, trying to get right. Here we go. Right. So
I want to start charging FPP.
Yeah. First question, in a healthcare environment where procurement often prioritizes unit price, how can we bridge the gap and prove the long-term return on investment of higher cost evidence-based infection prevention bundles? So how do we justify the cost? Now, I'll look at Ryckie to sort of say that. You know, Ryckie, we think something's great. I go to my procurement team and say, I want ChloraPrep now. How can I justify that product? How do I measure that long term? How do I convince my procurement team, my finance officer, that it does what it says on the tin?
Oh, I think you're probably much more qualified to answer that. But we get with the same retort of write us a business case, but that should be a very short business case of this is best for the patient. There's evidence, so there's guidelines, so, and it really shouldn't be a discussion point. And if they're trying to cut corners for cost, then that's completely unjustifiable.
Yeah, the way that I look at all of these things is that we often don't know what we don't know. So if I said to Ryckie, honestly, if you and I went round Leeds Hospital and picked a random, let's call it vascular surgeon, and asked them what their 30-day SSI rate, I doubt they would know it offhand, right? So once we get that, so first of all, you'd have to say, let's get your data so you know your true SSI rate. Then you implement the bundle, and then you measure out the back, and you will see, as long as it's evidence-based, as long as it's well implemented, a sort of 40 to 50% reduction by and large. And you can feed that back into the procurement finance team to demonstrate a cost-benefit analysis. What I like was Lindsay's bit about we should not be using unlicensed products if there is a licensed alternative that's there. So skin prep is a great example of that, right, Lindsay? That
yeah.
We should be using licensed products. And if we're not, we should be telling the patient. Tell me your thoughts on that, Lindsay.
I think from a patient perspective, I mean, a lot of hospitals have policies there, but it's about being having informed consent. It's about duty of candour. It's about actually making sure the patients understand that. And I think also trying to get patients involved in their journey. So we are trying to get patients involved. It's almost like a contract, but we don't give them a contract. We say, this is what you need to do before you come into theatre and have your surgery. And this is what we're going to do. But if we're not keeping to that, and we're obviously using different products, things like that, that's particularly going to increase the risk, and the patient needs to be aware of it. And I think more and more patients are aware of what's being used on them, and some of them do explore it. Not everybody, but some people do. I mean, I know from a healthcare professional, I'd be asking loads of questions, but I've got that information and that type of head on. But general patients just won't think about it. They're trusting us to do the right thing, right, that is researched and evidence-based. And the evidence base tells us we should be using a licensed product, not an unlicensed product. And the risks of the data is there. It's in plain sight.
Yeah, I completely agree. There's a great question that says, what about changing of gloves prior to closure? Ryckie, what are your thoughts on changing gloves prior to closure? I mean, that's, just taking off gloves, throwing them away, isn't that a waste, contributing to plastic, etc.? Got any thoughts on the evidence behind that?
Well, the first thing that comes to mind is the cheetah trial.
Yeah.
That pretty comprehensively shows that reduced the risk of SSI, albeit, yeah, very difficult to implement. I've found there seems to be a bit of resistance, and to me personally, because I work in a slightly different space where the risk of SSI is ever so slightly smaller and op times are shorter, so glove perforation risk is quite low anyway. So it's a great question. I can't really speak very confidently on the topic, if I'm honest.
I'll tell you this: I do complex abdominal wall reconstruction. We use meshes. I have no resistance to when that mesh comes out, everybody changing gloves. It's almost become it was almost natural behavior before the cheetah study came out. And what the cheetah study did was sort of validate changing gloves at key interval points in an operation. If you've been doing a dirty colorectal operation, opening bowel, etc., it just always made sense to me that before you came to closing the abdominal wall, you'd like to change your instruments and change your gloves, which is what the cheetah study did demonstrate. I think at the end of the day, that small upfront cost in terms of equipment, sterilizing, plastic, is that cost is far outweighed by having to come back and deal with a complex SSI rate. So if you've got a deeper organ space infection, you'd be using an awful lot more plastic and instruments and et cetera, than if you'd done that. But here's the thing: changing gloves and changing your instruments isn't going to reduce your SSI rates significantly on your own. It's all part of a bundle, isn't it? Yeah. Wouldn't you say that Lindsay, that everything we're talking about should be brought together? It's marginal gain theory, isn't it?
Each one affects the other. So when you're talking about the changing of gloves, I mean, I used to work with a lot of breast surgery, so they're doing cancer surgery. They always used to irrigate with water because of osmosis, so they're not passing a debris or the risk of cancer cells. They would change the gloves when they're at closure. They would use a clean tray. We're now seeing that coming in with cesarean sections, and there's data to state that that is reducing the risk. When you're doing major surgery, which I used to do, I used to have an underglove, and it's amazing when you're using a lot of heavy equipment, Omnitracs and various different devices, you do get strike through. So you're trying to reduce the risk of you getting an infection, but actually changing your gloves and actually changing your gown, your instruments, and actually putting the clean drapes around the incision site. That's what some people do. So they go a bit further than just changing the gloves. I'd never seen the evidence from the breast surgery that I've seen, but I think there is data coming through. I've not seen and had any information disseminated to me about a risk or a raise in infection, but I think if it was there, they would be saying it. So why are we doing it? What is the rationale for this? I think that's important. We need to understand what the rationale is, what we're going to do, and have the evidence. And for, when you think about all the things you've said about the increased risk of infection and the costs, not just financially, but to the patient and everything else, I think a pair of gloves is worth it.
I completely agree. I'm going to get one question in, because this is something that I hear quite a lot. Look, what do we think about washing the wound with antibiotics, which is effectively the question in the comments, that they're saying that, we can cover meshes in gentamicin solution prior to implanting them. That's demonstrated a reduction in sort of mesh infections. What about irrigating wounds with gentamicin and antibiotics? What do we think about that, Ryckie? Do you have experience with this?
Yes. Firstly, the data is quite clear. So Meyer's latest review from that, I think Hannah is the first author of that.
Yeah, that's right.
Seismic piece of work from early last year, showing that antiseptics and antibiotic lavage were equivalent in outcomes, just as effective as one another. And interestingly, saline had the same effect as placebo. I was a pointless waste of time. So since that came out, I have changed my practice and tried to teach everyone I come across to be like, if you're going to bother washing out the wound at the end, wash it out with an antiseptic. Why would you not? It's safe, effective, But antibiotic, no, because not for lavage because of the concerns about resistance, antimicrobial resistance. So there's no gains to be had for lavaging with that. But impregnating implants, that's a different kettle of fish, and we could talk about that separately.
Yeah. Lindsay, any comments do you disagree with Ryckie there, or do you support his sentiments?
I would support what he's saying, and also what I've seen in practice. Also, the studies that I've read, and also something that the Delphi study is basically saying that we shouldn't be using antibiotic lavages. But the other thing, we were talking about meshes and how you put them in. I was always taught to perform a non-touch technique. So, you touch the implant the least amount of times possible. You don't open it if it's in an inner packet until the surgeon actually needs it, and only the surgeon touches it. So you're trying to reduce all of these processes to reduce the potential of contamination.
No, I agree. Ryckie, Lindsay, I'm with you on it. The evidence is very clear, as Ryckie just said, that, antibacterial, antiseptic versus antibiotic. Why, in this day and age when we're dealing with multi-drug resistance, would you just be sloshing antibiotics willy-nilly all over the place? I just wouldn't be doing it, given that there is a fabulous alternative on the market. So I'd wash out the wound, and we do all the time with an aqueous povidone iodine solution. I think that's a good place to end. I said 10 minutes, it's been 12. What I would like to say at this point, please remember to fill in your questionnaire to feedback forms to get your credits from the Royal College of Surgeons of England. I would like to really thank Ryckie and Lindsay for giving their time up, and for two absolute fabulous talks. I've learned something from both of you, as I do every time I hear you talk. So we look forward to hearing again from you soon. And also I'd like to thank all the people that have joined in and listening. We can see all the numbers up on the screen, and none of this would have been possible without the support of BD. So I'd like to give them a personal thank you as well. Until next time, everybody, wish you well, and enjoy the weather.
Thank you.
Okay.
Bye.
Thanks, Giles.
Thanks,
Cheers.
Giles. Bye.
Cheers,
Bye,
Lindsay.
Ryckie.
Bye.
Bye, Lindsay.